So recently I've been making my way through this book, the second edition of Orthopedic Physical Examination Tests, an Evidence-Based Approach by Cook and Hegedus. It seems the first edition was in 2008, this edition is in 2013, and it's just fantastic. I recommend that clinicians read it. For the patient or the average layperson, I don't think it's useful, but it really corroborates what I've been finding in the clinic for the last several years, not initially, but since I learned McKenzie's repeated movement testing, I've learned that so many of the orthopedic tests that we learn, there are hundreds in school, do not really hold a lot of water. They're not really telling us what we think they're telling us, meaning there's a lesion in this muscle or tissue or whatever because this test tells us so. And secondly, they're not necessarily reliable, meaning that if I do the test, I'm going to find the same thing as the clinician down the street or the clinician on the other side of the world. So what I find with repeated movement testing is that for most patients, if we move the affected joint in a specific direction, signs and symptoms abolish. And that means for people with elbow pain, sometimes it's moving the neck, sometimes it's moving the thoracic spine, sometimes it's moving the elbow, and other times there are true diagnoses that are more commonly accepted, not these derangements that can be moved in a specific direction, but instead a tendinopathy, for example, or a fracture, or inflammation. But what I find in the clinic is observable. It's something you can see. So to me, it's not that wishy-washy. Let's move your neck this direction every couple hours for a few days and see what happens to your elbow complaints. Does the elbow range of motion improve, elbow strength improve, elbow pain, numbness, tingling into the forearm, etc. So I put a lot of faith into that kind of testing because it's so observable. Repeated movement testing has been shown to be reliable in the lumbar spine when clinicians are trained to a certain level. But if I have a clinician who just learned repeated movement testing last week, and you have myself who started learning it, I think back in 2014-ish, we're going to get different results. So the clinician has to be trained to a certain level, just like with any test. But repeated movement testing being more algorithmic is more challenging, takes more dedication, more time, more effort to learn on the part of a clinician than doing a quick elbow, varus, or valgus test. But what I wanted to highlight today, other than the fact that this is what I've been observing in the clinic for years, is that these tests that we learned, I just abandoned most of them because they don't help. They don't help me find the diagnosis. And that's where we start, finding the diagnosis, because once we have a diagnosis that we're confident in, then we can apply the matched treatment that's appropriate to that specific diagnosis. If you think someone's elbow pain is coming from a tendon, you're going to do very different treatments than if you think someone's elbow pain is coming from a joint derangement in the mid-cervical spine that needs left side bend toward the affected elbow to resolve. So what I want to highlight is Chapter 7. Chapter 7 is all about elbow tests. Most of these tests I would call OSTs, orthopedic special tests. Again, there are hundreds. You had to learn them in school. You had to learn them, obviously, to pass the boards, not only to be a physical therapist, but I had to know these for the board certification exam to become an orthopedic specialist in physical therapy. So they mentioned the Cosen's test, which is for lateral epicondylitis. Sometimes we call that a lateral elbow tendinopathy or epicondylgia, a couple different words, but it just means the tendons on the outside of the elbow are dysfunctional usually. So I remember this test by name, the Cosen's test, and the authors here find that there is no diagnostic accuracy studies have been performed to determine the sensitivity and specificity of this test. So that made me really curious why I even learned this test in my doctoral program, because even though the test is named after Cosen and Cosen did a study on it, it doesn't prove there's any worth to this test to assess if someone's elbow complaints are coming from lateral epicondylitis. So I went back to my text from DPT school. This text I think is from 2008, so I probably read it in 2008 or 9 or 10 because I graduated from the University of Miami's doctoral program in physical therapy in 2010. So I looked up the Cosen's test because I was like, why did we learn this if it was just kind of an idea that hadn't been proven diagnostically? And there is a paragraph about the Cosen's test on page 379. This book, for reference, is over 1,000 pages. Lots of tests. We learned lots of tests. And there's no footnote. There's no reference. There's nothing that says this test has actually been studied to be useful, to be helpful in the clinic. So again, this is the other version that really goes through all the tests that we learn, maybe not all of them, but most of them. These authors give you the background of the studies of the tests. They tell you the sensitivity, they tell you the specificity, they tell you the likelihood ratios, they tell you the reliability, and they also rate the bias of the studies, and they come to their own scoring, which is between 1 and 3, 1 being the test is very useful and helpful in the clinic, and 3 being it's not very useful. And then sometimes they just have a question mark, like with this one for the Cosen's test. They can't even give it a 1, 2, or 3 because there's no studies to really base that number on. So this is a wonderful resource. Like I said, it kind of corroborates what I find is that most of these tests are not helpful. And that matters because most clinicians who work in orthopedics, MDs or DOs or ATCs or DPTs, they're relying on these tests because we were taught them in school and we thought that they were actually useful. But if you just flip through this book, which is not over 1,000 pages, it's about 525 pages, you're going to find that most of these tests get a grade of a 3 or maybe a 2. There aren't many tests that get a grade of a 1, meaning that they're free of a lot of bias, they have good sensitivity and specificity, and good reliability. And therefore, when you do this test on a patient, you can be sure that you're getting a pretty accurate assessment or a good assessment process. They mentioned the clusters of tests, which yes, have been introduced in recent years. Clusters of tests, meaning the test by itself isn't useful, but if you do 5 tests together and you get 3 positives out of 5, it could be useful. And sometimes I think that's putting garbage tests together and asking for a 3 out of 5 garbage test to be helpful, but sometimes they do, or a cluster does hold merit. So again, looking through this textbook, you don't see a lot of 1s. You don't see a lot of 1s. And I was not surprised, but kind of surprised that there were so few tests that were given an excellent grade for utility in the clinic. So again, if your orthopedic clinician is basing his or her examination on these tests, then you've got to ask if the diagnosis is correct.